today's exciting one. I think osteoporosis is, from at least my understanding, something that isn't really well understood by patients, right? And we're going to be talking about the importance of bone health, and because you need to have healthy bones, right, to stay active. So that's what we're all about with functional medicine. So just a quick disclaimer, what we're talking about today is not medical advice. This is really just for educational purposes only. If you want functional medical advice, you can become a patient at MedMatrix. This is really just for educational purposes. I'm joined by the absolutely fantastic Dr. Rose. Dr. Rose, can you give a brief introduction, kind of your background, how you got into functional medicine, and what, kind of your understanding of or experience in bone health and osteoporosis?
Yeah, I'm a naturopathic physician. I've been practicing for over 20 years, and I have seen a lot of people, mostly women. I continue to see a lot of patients who come in with a diagnosis of osteoporosis, sometimes osteopenia. We'll talk about the difference. And it is unfortunately kind of very common. And I've just become really fascinated with the intersection of hormonal balance, nutrient balance, keeping inflammation to a certain level, and the different ways that we can prevent both osteopenia and osteoporosis, and sometimes even reverse that. So it is a super important topic. I think you're completely right that it's not well understood among many or most patients, and unfortunately even among a lot of medical providers. It's just not something that's, at least historically, been prioritized in medical education. And I think there's some limitations both in terms of the diagnostics and definitely the treatment approaches. So super important topic, and probably one that doesn't get quite enough attention, in my opinion.
Gotcha. Well, in like 30 seconds or less, why do you feel like osteoporosis doesn't get the attention it deserves?
Well, this might be a little bit of a controversial subject, but maybe because it primarily affects women, that might just be part of it. And other than that, I think it's something that isn't screened for and detected until usually women are in their 50s and older. And it's kind of caught, after it's, ideally, this is kind of something that's addressed decades earlier. And that's just not the way that as we have discussed frequently on this podcast, is just, that doesn't really fit into the conventional medical model, where we do have good screening tests like the DEXA scan. We'll talk about the pros and cons of the DEXA. But the fact that it's not done earlier means that these are, kind of the lower bone mineral density, again, osteopenic or osteoporotic status of a woman is not detected until it's already developed. Whereas if we had a healthcare system that was really, really proactive and really invested in preventive care, we would be catching it much earlier. We would be preventing it and really improving bone mineral density for women and men. And therefore, when we improve bone mineral density, we're reducing a person's risk of fracture.
Why does osteoporosis affect more women than men? Is this a lifestyle thing, or is this a genetic different thing?
It's largely hormonal. It's that estrogen, primarily estradiol, which is the strongest of the three estrogens, is really important to basically preventing the breakdown of bones. So there's two types of cells that we talk about. Bone is not static. It's kind of this like metabolically active tissue that's always remodeling. And the two key cell types are osteoclasts, which are the resorbers. They kind of break down old or damaged bone. And then there's the osteoblasts, which are the builders. So they're putting down new collagen matrix and kind of mineralizing it with calcium and other minerals. So you've got these two types of bones, and in a healthy individual, with, I guess I would say, optimal levels of estradiol, they're kind of in balance, right? Like the activity of the osteoclast matches the activity of the osteoblasts. When a woman hits menopause, there's a pretty abrupt drop in her estradiol. What the estradiol has been doing is kind of putting a brake on that osteoclast activity. So it's basically been helping to maintain the balance. And then there's this really kind of sudden drop of that, the brake comes off the osteoclast activity, and suddenly you get much more breakdown than you do building up. And it's, so that alone is a big reason why women tend to have weaker bones. I think there's also, again, this is a hormonal thing, and we'll talk probably a little bit more about the importance of optimal skeletal muscle mass and muscle tissue, and that's protective, and that in addition to the actual bone mineral density, that's going to help an individual maintain balance and stability, and again, prevent fracture. When in both women and men, when you see a drop in estradiol and a drop in testosterone, you're going to inherently lose some of that strength. So I think to answer your question, basically it's large. It's a hormonal issue.
Okay. What about so all right, we understand that hormones play a big role in bone health, but how do nutrients play an important role in bone health?
So everybody talks about calcium. We need optimal calcium. We need specifically, some calcium forms are absorbed better than others. In order to get optimal absorption of calcium, you need optimal levels of vitamin D. So if people are deficient in vitamin D, then they're not going to get optimal absorption of calcium, and that's just like a real deficit for the building of the bones, for kind of that mineralization, and therefore strength, that osteoblast activity.
Gotcha. Okay, what are good levels that you like to see in your patients for vitamin D and calcium?
Yeah, so the vitamin D, this just came up with in a couple of my visits with patients today. There is a bit of a split between kind of the conventional medical opinion on what normal vitamin D is versus in functional medicine, what we consider to be optimal. So for any individual, no matter the sex, no matter the age, I usually like to see serum levels of vitamin D at least at 60. And in addition to the bone mineral density piece and calcium absorption, that's helping to lower inflammation. It helps with autoimmune tendencies. It helps with mood stabilization, immune strength, etc. In regards to osteoporosis, bone mineral density, I really would like it actually probably on the high end of that, so closer to 80. And when we see that, again, there's that optimal calcium absorption. We are also, I shouldn't ignore vitamin K2. We're always including in our recommendations vitamin K2, because as you're getting that optimal calcium absorption, you want that to be shuttled to the bones and not to the arteries. And so that's where the vitamin K2 comes in.
So can you explain K2? Like, what do you mean K? So yeah, can you explain that a little more?
Yep. So basically there's a couple different types of K2. There's one that's, I think MK4 and MK7. And when that is, again, basically when that is taken with the vitamin D3, then that's benefiting the bones because of where the calcium is going. So people often are taking vitamin D3, but they haven't been instructed, or they just don't know enough to take the K2 with it.
Okay, so sorry, can you say that again? What does K2 actually do? So K2 directs the
Yep.
vitamin
I think
D?
of it as like kind of like it guides where the calcium should go. So you need a couple things. You need to get enough vitamin D that you're optimizing the absorption of calcium, and that can just be the calcium in your food, and or if you're supplementing with an additional calcium. So you want to kind of optimize that absorption, and optimal levels of vitamin D are going to let you do that. But then once that vitamin once that calcium is in the bloodstream, where does it go? Do you want it deposited in the arteries? Not so much. That's going to increase your risk of having a cardiovascular event. You do want it to be deposited into that growing bone, that matrix of the bone.
Okay,
So
and
that's what K2 does.
Okay, so if you have low K2, calcium's going to go to the arteries. If you have optimal K2, it's going to go to the bones.
Correct.
Gotcha. Is that something that you test for in the initial panel, K2?
We don't do K2. No.
When do you want when do you want to get a patient's K2 levels?
On all honesty, it's not something I order routinely. But I think if we were, so I'm not going to go too much into this, but sometimes, like if there's a parathyroid disorder, if there's kind of some conflicting or confusing test results in terms of calcium, in terms of D3, and you're kind of digging a little bit deeper, then potentially we would order that.
Okay. Gotcha. Does thyroid play a role in bone health? I know it's all connected, but does thyroid play a significant role in your bone health?
I mean, not as much as parathyroid. Parathyroid really does play a big role in terms of calcium absorption.
What is parathyroid? Sorry.
It's a second gland that's kind of next to the thyroid. And so if there's an issue with the parathyroid gland, then that can basically impact your bone mineral density. I actually should correct it. There is an issue with thyroid. If usually what it is, it's actually more with hyperthyroidism. So if somebody has, which is a less common form of thyroid disease than hypothyroid, which is the sluggish or the slower functioning thyroid. So hyperthyroidism is an autoimmune condition, and where there's kind of like an overactivity of the thyroid gland. When that happens, or if somebody is kind of over medicated for hypothyroidism, and that one marker that is commonly used, the TSH, the thyroid stimulating hormone, if that is too low, so if it's kind of like because of medication, it's basically been suppressed, we do see that lowers bone mineral density. That does kind of increase your risk of fracture. That has to be going on for a while. If somebody has kind of, TSH that's too low for 3 to 6 to 9 months, it's not going to have a huge impact. We're talking years.
Okay, sure. So what is the conventional medical approach to osteoporosis, and what is the functional medical approach to osteoporosis?
So let's start a little bit with the testing. As I said, in an ideal world, I think we would maybe be doing some of this screening at an earlier age. I honestly don't know, like in that insurance world, I'm not sure when insurance is going to start to pay for a DEXA scan. But again, in an ideal world, if somebody is at a higher risk, and we can go over what those risk factors are, I would say, screen earlier than 50, certainly earlier than 60. But conventional medicine uses a DEXA scan, and this is kind of it's a form of an X-ray. There's two beams that are used in a DEXA scan. One is looking at soft tissue, and one is looking at bone. And when they do the calculations, this is a low dose X-ray, by the way. When they do the calculation, they computer basically subtracts the soft tissue absorption. So one beam is absorbed more by soft tissue, the other one by bone, and then the computer subtracts it, and you end up with an estimate of bone mineral content. And then they basically have this formula, and then they get the bone mineral density, and that's expressed in grams per centimeters squared. So it doesn't directly measure bone strength. It measures bone density, which they can correlate with fracture risk. But again, it doesn't show kind of the actual quality, the architecture, or any micro damage. There is another test that I have been researching a little bit and starting to refer people to. It's actually a form of an ultrasound as opposed to an X-ray. It's called an REMS, R-E-M-S, echo light.
Okay.
And this actually, some people like it because they want to avoid X-rays. The ultrasound is very safe. This gives I believe both a bone mineral density and what's considered to be your FRAX score. And that's your risk it's like your 10-year fracture risk. So that's, again, I'm not sure how often that's going to be covered by insurance. And I know that, like, for us, the closest place where people can go is Massachusetts. There's a clinic that offers that. But I think we are starting to see these kind of alternate ways of screening for it. In terms of treatment, it's pretty limited in conventional medicine. There's two categories of medications. One is anti-resorptive. So those are the ones that people have maybe heard of more commonly, the bisphosphonates. The most well-known brand name is Fosamax. The generic of that is alendronate. And what that's doing is basically slowing down the bone breakdown. So it's kind of, again, slowing down that osteoclast activity.
Okay. I know, like, some medications, you, like, the medical team here are more critical of, like, hey, this is kind of maybe not a cop out, but it's like not the best solution here.
Yep.
Versus some medications like, hey, this is actually a really good thing. So where, like, can we dive more into the conventional medications for osteoporosis as far as, like, what are the long-term side effects? Is there a better root cause approach? Can they be used in conjunction with a functional approach?
Yeah, I mean, the negative with so a couple things. I mean, I'll get into kind of how we in functional medicine here at MedMatrix, how we like to approach it. Those bisphosphonates are often used for people who kind of have what's considered to be like a modest decrease in bone mineral density. It does reduce the fracture risk, especially in the vertebrae and the hip. It's often like what's considered to be a first-line therapy. It does not rebuild bone, and it potentially, with long-term use, which is oftentimes that's the intention, is like you just need to stay on this. It may actually suppress some of that building, that osteoblast activity.
Okay.
But those are the ones that we're going to see the most often. The other category is these kind of like anabolic therapies, and that's more for that build, and like idea is to at least stimulate osteoblast activity. These are often used when people have a history of fracture, they have severe osteoporosis. But there is part of what we do in functional medicine is we practice personalized care, and it's really important to know, like, what are some of the other medications that a person is on, in addition to actually like what they've been on in the past, what are their risks. But for example, like if your doctor is prescribing a certain osteoporosis medication, you need to talk to them about other medications that you might be on. So if you're on an acid blocker, if you're on a proton pump inhibitor, that's going to change kind of statistically what has been shown if that osteoporosis medication is actually going to be effective or actually potentially put you at a higher risk of fracture. So there was this one study that was done that when women, it was done with women, I think it was all women. This one might have been both women and men, but it was basically a meta-analysis. There were almost 60,000 people in this study. They were on what we call PPIs, or proton pump inhibitors, so the medications that people take to help with heartburn or GERD.
Okay.
And it showed that those people, while taking a bisphosphonate, actually had an increased risk of fracture by 52% compared to people who were just taking the bisphosphonate.
Okay.
So it matters what other things are going into your body. So in terms of like the question of, are there certain conventional medicines that we do like and that we do encourage, it's all individualized, right? Like maybe for one person, that's what makes sense right now. But not if that person is already on a proton pump inhibitor and they really need to be on that medication. So does that kind of answer that question?
Yeah. So I got a bunch of questions here that I have written down. First off, what is the difference between osteoporosis and osteopenia? And like what's actually happening inside the bones with these kind of different diagnoses?
Yeah, so they're basically on the same, they're conditions that are on like the same spectrum of bone loss. So osteopenia means that your bone density is lower than normal. It's like a warning sign that the bone is thinning. And then like technically on that DEXA scan, you're osteopenic if your T-score range, that's how they talk about it, is -1 to -2.5. And so you're not really at a high risk of having a fracture. And not everybody with osteopenia is necessarily going to progress to osteoporosis, but you do have an increased risk. Osteoporosis on that DEXA scan is worse. It's like greater than -2.5. So -2. I have people coming in and they're like, I had a -4 on a DEXA. So that's definitely osteoporotic. And that's like your bones are porous, fragile, more likely to fracture. So that internal architecture of the bone is relatively weak. And most common fracture sites are like hip, the vertebral spine, I guess wrist. I think it's wrist is mostly because that's often just what you're falling on, right? Like when you're trying to stop yourself, that's what you hit. So I think that's partly why that is a common site.
Okay. So is bone loss really just a part of like getting older? Like you're just going to get older and your bones are just going to get more fragile? Is that just part of it?
Obviously age increases your risk, right? Now, that is not a factor that that's not a variable that we can change. In addition to aging, it's that estrogen decline, especially postmenopausal. Other risk factors are chronic inflammation. Another risk factor is what we call like hypercortisolism, and that can be caused by medications like steroids or corticosteroids, so things like prednisone. The nutrient deficiencies, which we discussed, and having a sedentary lifestyle. That's going to put you at higher risk. Some of it's genetic, right? Like some people are just kind of born with thinner bones. But there are the genetics you can't necessarily change, and the aging you can't change, but there are factors that you can change.
Okay, I guess like what I'm getting at is like what's in our control when like let's say your mission is to live as long and strong as possible and you want to have really strong bones as you get older so you can continue to be active. Like what are all the things that you should be doing to make that a reality?
Yeah. So I'm a little bit on a personal mission to talk to my young female patients and to the people that I know who are parents of women, girls really ages, 8 to into their 20s, right? That is like a prime window of when we can still really, there's a lot of bone building activity. We can still kind of optimize levels of vitamin D and calcium absorption, and really build like a strong foundation. And so that when she does get into those perimenopausal years and the menopausal years, if she's in a situation where she doesn't go on bioidentical HRT and her estradiol drops, and or she has family history and like these genetic reasons why she's at a higher risk, we've given her this gift of at least having that optimal vitamin D and optimal calcium in those decades of her life when we can really make a big difference. So that, and for those of us who are older,
Yeah, I was gonna say.
optimizing vitamin D, optimizing calcium, optimizing protein intake, really kind of targeting inflammation. So kind of chronic inflammation is going to play a role. Handling inflammatory conditions, ideally in a way that does not involve chronic use of steroids, because that's going to hugely increase your risk. The other another huge category of medications, as I mentioned earlier, is proton pump inhibitors. So a lot of people are on medications like omeprazole, famotidine, over-the-counter Prilosec, Pepcid. Those are just the over-the-counter versions of the same medications. And there's no controversy around the fact that chronic use of those medications, which really are supposed to only be prescribed for 2 weeks, but rarely is somebody only on it for 2 weeks. They usually end up just kind of staying on that. There's a huge increase in risk of losing bone mineral density and therefore increased risk of fracture. So in terms of preventive medicine, there's things that you can do, but there's also these categories of medications that we want to avoid. So we want to avoid the synthetic corticosteroids if we can. I talked about the PPIs, and then this is an interesting one. SSRIs and SNRIs, so these kind of antidepressant medications. SSRI stands for selective serotonin reuptake inhibitor, and then there's serotonin norepinephrine reuptake inhibitor. Again, super common. Again, we've talked about this on the podcast. A lot of people coming to see us are on these medications. So there was this one study, I think it was done in Canada. It tracked patients for 10 years, and it found that taking either an SSRI or an SNRI was increased with a 68% increase in fracture risk. And the reason they think is that when there's this kind of artificially elevated level of serotonin, which is what happens when you're on these medications, the hormone, it kind of becomes unhealthy, at least for the bones. That elevated serotonin inhibits the osteoblasts. Those are the builders. Those are the cells that are creating bone. So you're basically not changing the osteoclast activity. You're still getting the cells that are kind of breaking down the bone, but you're not matching it with the builders, the osteoblasts. Yeah.
Wow. Interesting. So is having strong bones as simple as like just taking a vitamin D and calcium supplement or as early on as you can?
No, these are, it's multifaceted, right? It's like, it's the preventive measures, like you just mentioned. It's treating gut health in ways that doesn't involve chronic PPI use. It involves dealing with mental health issues that I'm not saying that somebody should never go on an SSRI. Like there's a time and a place where people, it's the right thing to do. But, in terms of like really looking at like practicing root cause medicine and really looking at prevention, it's this chronic use of these medications that's just going to, all of these compound to increase your risk of osteoporosis. And so addressing emotional health, mental health in ways that are not just relying on these SSRIs or SNRIs, addressing heartburn and gastroesophageal reflux disorder in ways that it's not just using a PPI. So not these kind of like, mask the symptom type medicines, but instead like actually healing things. I mentioned the synthetic corticosteroids. Chronic stress is, for some people, and I know we've talked about this as well, is chronically elevated cortisol. It's not going to be quite as damaging as like a synthetic corticosteroid.
So you're saying stress can kind of lead to poor bone density.
Again, overall, it's going to contribute to your risk of osteopenia and osteoporosis, because that chronically elevated cortisol, it's basically balanced with that other hormone, oxytocin. They kind of balance each other. So oxytocin actually benefits your bone mineral density, whereas cortisol kind of strips the bones of collagen, and you want a healthy balance. So if you don't kind of have enough of that oxytocin and you have too much chronically elevated cortisol, it's just one more thing that's going to slightly increase your risk of fracture.
Wow. Okay. What about gut health? How does your gut health kind of set you up for, like, if you have bad gut health, are you almost guaranteed to have poor bone health later in life?
Not necessarily, but if you have impaired gut health, you probably have some level of malabsorption, right? It's harder for you to absorb.
So that's how gut health plays a role in it.
Primarily.
It's the absorption, and then your nutrient deficient.
Absorption of the nutrients, yeah.
Gotcha.
Yeah, I would say that primarily. And again, if you have gut health issues and you're kind of masking it with a proton pump inhibitor, you're increasing your risk of a fracture.
Okay, sure. Let's see here. So if you've been diagnosed, like when you have patients who come in with osteoporosis and osteopenia, like, is there any coming back from that? Like, can you get them back to a point where their bones are like they used to be to some extent?
You can. I mean, so one thing that I like to do is talk to both women and men, but mostly women, about getting their serum levels of estradiol up. Now, the research does unfortunately tell us that after the age of 60, that it's hard, like even if I do put a woman on estradiol, if she's over the age of 60, it's harder to kind of make huge gains just with that one therapy alone in her bone mineral density. It does help. It's better than not. But if I can catch a woman before she's around the age of 60, then we still kind of are in a good window to, either reverse, get a woman out of that osteopenia category, or move her from the osteoporosis to the osteopenia, and then maybe eventually out of that range. There's really the biggest, if a woman is not on bioidentical HRT, specifically that estradiol, it's that 5 to 10 years post-menopausal where that's kind of where that bone, that breakdown really happens, right? Like that break comes off of the osteoclast, and there's just the rate of bone breakdown exceeds the bone building. And so if we can catch a woman before menopause or early in that 5 to 10 years right after she's menopausal, then we have a better chance of preventing or reversing.
Okay, gotcha.
And then same with the nutrients, right? Like, yes, it's better to do it when somebody's younger, but it's certainly still helpful and beneficial to maintain optimal levels of nutrients.
Okay. Yeah, makes sense. So I
haven't even mentioned kind of the physical activity piece yet, which is huge.
Sure, let's get into it. How important is physical activity to not only staying active as you get older, but your bone health?
It's huge. I mean, you really need that kind of resistance. It's like you need to kind of, yes, I think I mentioned about the muscular strength and stability and balance, but you need, in order to kind of, so for example, we all know the thing about like astronauts, right? That they really lose bone mineral density. There's no gravity, right? And so it's like the longer that they're up there, the worse it is for their bones. So just simply that kind of that weight on the bones. That's why we always hear about like weight resistance and weight bearing exercises to help with bone mineral density. Cardiovascular activity is cardiac work, running, biking, that's all great. But you need something to push against the bones to kind of maintain that density. And so what we're talking about here is reducing your risk of fracture. So in addition to the bone mineral density, it's especially when people get older, it's reducing the risk of them actually falling. So if a person is osteoporotic and they fall, there's just a much higher risk of them breaking a bone as opposed to somebody who falls but is not osteoporotic. So it's also behavioral, lifestyle. So we talk to our patients about removing throw rugs, around the house, having adequate lighting in the hallways, putting grab bars on stairwells, and especially in the bathroom. Like, a lot of falls happen in the bathroom. You want to make sure that you have a grab bar, even like next to the toilet, in the shower. You want to remove kind of lips between, like a threshold, if there's kind of something that, you could easily trip over. So those things seem kind of, those are kind of not talked about, but it's huge. Like, there's like kind of some things that just need to, like, if somebody can just come through an older person's house and like reduce those risks of actually falling, that's huge. And there's physical therapists who specialize in this and like have people do specific exercises so that physically, neurologically, they are at less of a risk of falling.
Sure. Do you think if you did everything right, like, obviously everyone's different, but like how long can you realistically prolong the having weak bones if you did everything?
Like, how long can you stay out of that osteoporotic window? Is that what you mean? Like,
Yeah.
I mean, again, it's looking at all these factors. I mean, yes, there's the genetic piece, but I think if you start young enough and you adopt enough of these measures, then and I sound like a broken record, but I think the hormonal piece is really big. And that actually includes men too. Like, if men have low testosterone, gets what we call aromatase, or like converted to estradiol. So if they have low testosterone, that means they're also going to have low estradiol. And that's going to give them a higher, like lower bone mineral density too. So it's not, obviously women have a higher risk, but it does apply to men as well. So if we can optimize hormone levels, nutrient levels, like, early enough, I think there's a really high chance of preventing osteoporosis.
Okay, gotcha. So your favorite markers to look at kind of like osteoporosis are obviously the DEXA scan, vitamin D, calcium, K2, and what else? What are other important estradiol? What are other
hormones? Estradiol, testosterone. I mean, as you know, in our panel, we're looking not just at total testosterone, we're looking at kind of free testosterone, bioavailable testosterone, which shows us what the body's actually tapping into, not just total. And I'm looking at protein intake. We usually are recommending more than what the RDA is, although I'm not sure what the new specifically exactly what the new protein RDA recommendations are. I know it went up, but we're looking at ideally the amount of protein, kind of a ballpark figure is if you multiply your weight in pounds times 0.59, and that'll be the number of grams of protein you want to aim for every day. So if you weigh 140 pounds and you multiply that times 0.59, I think you end up with something like 65 grams of protein, like at minimum. So that's going to be beneficial. So yes, those are you mentioned like the blood work that I'm looking at, potentially a DEXA scan, or as I said earlier, that ultrasound, that REMS scan, and then lifestyle wise, what is somebody's diet like?
Okay. Yeah. And then taking like a vitamin D,
Three would be okay.
calcium. Yeah, and calcium supplement as early as possible. Is there anyone who shouldn't be taking a calcium supplement or
I'm
vitamin D
not
supplement?
necessarily recommending calcium a lot. I mean, I think you definitely can take calcium.
Mm-hmm.
Again, a lot of it has to do with somebody's diet and how much I think they're getting through their food. But if they are taking calcium, calcium carbonate is kind of the traditional form. That's not really easily absorbed. Calcium citrate is absorbed more easily, but at one time, the body isn't great at absorbing more than 500 milligrams at a time. So there's not really any point in overloading on the calcium.
Okay, gotcha. I forgot what episode I think we talked about this in the deficiencies podcast. But milk, okay, because
Milk.
I had to bring it up because we're doing a podcast about bone health and osteoporosis. So, for those who haven't watched our deficiencies episode, what's the real with milk? Is milk actually going to give you strong bones or no?
So, yes, dairy is relatively high in calcium, but there's so many other ways to get calcium. So, dark leafy greens, nuts and legumes or beans, seeds, and oftentimes, and there's different forms of dairy, right? So, for a lot of us, like a fermented form of dairy, whether it's yogurt or kefir or certain types of cheeses, our body handles that better. We digest it better, and then you're still getting the calcium.
Mm-hmm.
Milk is often harder to digest for people. And I think, as I said on that other podcast, there's a little bit of a generational divide. I think that marketing campaign that happened however many decades ago really worked. And so
Mm-hmm.
I have patients in their 70s and 80s who are, continue to drink a glass of milk with every meal, sometimes with the idea that it's like, for their bones. And I think you can get optimal calcium without the somewhat inflammatory and inflammatory side effects, the digestive side effects that many people do from just drinking straight up milk.
Gotcha. Heard. Okay. Let's see here. Can you walk me through a patient case study that you did with relating to osteoporosis, bone health, etc.?
I can. Yep. So this is somebody that I'm working with currently. Now, the one thing I do want to point out is that, as I think it's become evident, unlike some of the conditions that we are treating at MedMatrix or in functional medicine in general, where we can kind of gauge the success of our treatments relatively quickly, by how the person feels 3 months later, 6 months later. Things like bone mineral density, like this is, we're in this for the long haul, right? People aren't getting DEXA scans every 3 months. They shouldn't. So just to have that kind of caveat that, I'm working with people for a long time, and sometimes success simply means they haven't fallen, or they fell and they didn't break something.
Mm-hmm.
This case is a woman that I'm working with right now. She is 68. She came to me originally for primarily digestive issues, so chronic heartburn, chronic gastroesophageal reflux disease, GERD. In addition, she has known for a while that she has osteoporosis. So she came to me taking omeprazole, which again is one of those proton pump inhibitors. Again, had been on it for quite a long time. Was also on, I think she's still on alendronate, which is a bisphosphonate, one of the more common ones. Trade name is Fosamax. Again, she's been on that for a long time, but her most recent DEXA scan did not show any improvement. I don't remember what her T-score is, but it's in the osteoporosis window, not osteopenic. So her at her first visit, I saw on her blood work that she was deficient in vitamin D. I put her on a decent amount. I might have just started her even on just 5,000 IUs, which is, in my opinion, not a lot. 5,000 IUs of D3 with K2. We started working on her gut health. She saw her primary care provider, who either tested her vitamin D, or I think they tested her vitamin D, and it was came back at 33, and they told her that that was too high, and they wanted her to stop her D3 supplement. So again, it's just a difference of opinion. We don't really see people getting into toxicity levels until it's like around 150, but conventional medicine feels like anything like 33 is too high. But for her bone mineral density, I wanted her to be like at 80.
So what are you doing? Just curious, like, I'm sorry to interrupt the story, but like, what do you do in that scenario? Because like,
I say exactly what I just said to you. I say this is a difference of opinion. I say I am prioritizing your bone mineral density, and this is what we see for optimal calcium absorption is that we want to keep your vitamin D elevated, and we are a long ways away, in my opinion, from what I have read and what I've learned. We are a long ways away from toxic levels.
Man, that sucks for the patient, because then they're like kind of between a
torn. Exactly right.
Yeah, that's really tough.
Yeah. So a little bit of his, she does have a couple, there's been a couple fractures, I think, in the wrist.
Mm-hmm.
So I changed the form of her calcium to calcium citrate because it's more absorbable. Again, I've been like optimizing her gut health. So she has been able kind of on her own to get off of that proton pump inhibitor. So cool. right there, she's lowered her risk, right? I mean, it'll take a little while, but basically just by being off of that, she no longer has that compounded risk. And so so she was able to do that with some nutraceuticals. And I did start her on some bioidentical HRT. Again, she is a little bit older, like how much are we going to gain? We are going to get some gains from that, not as much as we would if she were 10 years younger, but it's still better than not at all, and it's still safe. And I feel like the benefits outweigh any kind of risks for her. And then I might be considering kind of some additional hormonal balancing to just, again, continue to optimize that like the skeletal muscle mass as well as the bone mineral density. So she's really exercise wise. She's maybe unknowingly been focusing on cardio, but I'm also trying to help her incorporate more weights and more of an emphasis on balance and flexibility.
Awesome.
So, yeah. So again, I don't have a, oh, look, her DEXA scan is now amazing, but I think we're going in the right direction.
Yeah. I mean, what's awesome is she got off the
PPIs. Yeah.
Yeah, that's pretty cool. What I'm going to do right now for patients who are joining is put a link in the comments on YouTube where you can actually book a free discovery call as a new patient. We really appreciate, we love when patients do the work and educate themselves. Patients who are more educated about these things and their health definitely see better outcomes. So yeah, click the link below. You can book a free discovery call if you're looking to work with us as a patient. We do accept a limited amount of patients per week. So if you're interested, just make sure you click it, book it. We'll leave it up for a couple more seconds here. With that said, Dr. Rose, do you have anything else that you want to add to kind of this discussion today?
I guess if I had one kind of take-home message for people, it would just be circling back to the beginning. I just think that, unfortunately, there's just been some real limitations in conventional medicine in terms of treatments. And there is a lot that we can do in kind of a holistic way, whether it's in lieu of or in addition to some of these pharmaceuticals. And so I oftentimes have people coming in with osteoporosis and they just feel a little hopeless. And they really shouldn't. There's other tools out there that do make a difference.
Mm-hmm. Yeah. And thank you guys for saying thanks. We appreciate you. It's always fun having the live audience. So with that said, we'll see you guys in the next one.
Thank you.